Seconds, and then we'll get started on what should be a fun conversation. All right, I think we can get started. Even for those who are joining us a few minutes late, welcome to this session of Africa Dialogues on the 25th of April, 2025. My name is Edwin Macharia. I still have long hair for those who can't see. Just these things make it look a bit weird, but we wanted to make sure that everybody gets to see the and reminder of what's the conversation we are having today, which is World Malaria Day. A really important discussion ahead and an incredible panel of Africans at the top of their game and leading these conversations, not just on the continent, but across the world. Before we get started, want to just call to attention the slide that's being projected currently. For those who need interpretation, the instructions are on there on how to get interpretation. This conversation will be held in English, but interpretation services are available for our French speakers. So please use that facility so you can follow the discussion. My name is Edwin Macharia. I'm co-founder and managing partner at Axum, which is an Afrocentric impact systems orchestrator. We currently have about 80 people within the Axum ecosystem and 12 offices. Jealously, our newest office is in Zanzibar, which is unfortunately not where I'm dialing from, but I'm in Nairobi. But we have an office in Zanzibar where we're doing some incredible work with the leadership of that country on its economic development. Co-host with me, as always, is Dr. Gethenja Gitahi, who you will join us in a second to say hello, but did want to remind us on why this is such a critical conversation. The theme of World Malaria Day is Malaria with Us, Reinvest, Reimagine, Reignite. We all recognize Africa carries an overwhelming burden of malaria. 94% of all cases of malaria are on the African continent. 95% of all deaths from malaria happen on the African continent. So this is a critical issue for the continent as we go forward on how do we engage and tackle malaria, especially in the current context of fiscal space and bilateral, multilateral resources not being available. And we have to have this conversation on how do we as Africans reinvest, reimagine, reignite our fight against malaria so that our citizens can live fruitful and joyous lives without the burden that many of us grew up with. So without further ado, let me invite Dr. Gethenja Gitahi, who is my co-facilitator and co-moderator and co-creator of the African Dialogues, for his opening remarks. Dr. G, over to you.
Thank you very much, Edwin, and I hope I am loud and clear. Thanks for that intro. Today, colleagues, yet another Africa Dialogues and on a very topical issue. And Edwin has already stated some of those pressure points that we need and we have to push ahead on this agenda. As moderators, our role is to gather the individuals who have the most knowledge, who have the most practice, hours and years of practice on this issue, and to bring them to bear on these Africa Dialogues as we discuss lasting health change in the continent of Africa. Amref Health Africa and Axum have been working on this for quite some time. Now, we just came out of the Africa Health Agenda International Conference in Kigali. That was in March. And at the point we went to Kigali, it is just when the geopolitical shifts globally had shown their face, and the face was rather ugly because we had departure from health system support, departure from commodity support, departure from, generally all the areas of health systems that were being supported. But that doesn't mean, therefore, that us as African people, our governments, our people are not able to move forward. We are able to move forward. It will be a bit difficult, a bit bumpy. Originally, it may cost lives, which is unfortunate. But this moment of AHIC and this moment reminded us that it is important that the health of our people is in the hands of our people, and our people are their governments and their technical people and their domestic resources. And the fact that they are in the hands of our people doesn't mean that therefore they are alone. It means therefore they work with others, and those others then come and integrate to ensure that everyone is safe everywhere. So we appreciate our partners, but we're also reminding our government that it is important to own the health system agenda and own it in all ways, including designing your primary healthcare systems, designing your commodity supply, and then getting partners to support a common strategy, a common agenda, one plan, one M&E framework. And that's what we generally refer to as the Lusaka agenda, which is really a call for integration of the health systems. When we were discussing at AHIC, especially because of the exit of significant development assistance, there was a call generally to redesign primary healthcare to ensure that we reduce disease burden because disease is expensive, and we shift our health systems to be more preventative and promotive, and we reduce the burden of disease. Because, as we were told in school, prevention is better than cure. It's as simple as that. And we are saying that if African health systems were based on prevention, not cure, and cure only when necessary, then we would actually forego a lot of costs of cure and limit the little resources that we have. As I keep saying, Africa has only probably $40 per capita on domestic resources, tax-based resources for health, whereas our colleagues in Europe have $4,000 per person per year, and we have $40 per person per year. So we cannot do the job of $4,000 with 40. Therefore, we have to redesign and be context-specific to Africa. What do we focus on? How? And the overwhelming message is that there is a need to redesign the primary healthcare, the health system, to recognize this need that we need to shift our resources to prevention, to promotion, so that we invest in health, not in health care. And that was critical. And this you will see in the malaria case, because with more than almost 250 million cases of malaria annually, an estimated cost of $5 to $10 per case on treatment, an estimated cost of more than probably $300 for admission, it is a significant burden. And Africa spends hundreds of millions of dollars, if not billions, in terms of the overall cost of malaria in care, but also the cost to the communities. So we really want to look at this and say, at this time when Africa needs to rethink to own its health system, what are those tools, innovations, science, approaches that we can use to shift to prevention rather than cure? As Edwin said, the theme today for World Malaria Day is Malaria Ends With Us. Reinvest, reimagine, reignite. And this is exactly what we're doing at Africa Dialogues today. And I would like each one of you, I'm an advocate, so go to your chat and say, Malaria Ends With Me. So just post that chat as you run it down. And as you do that, we are going to be joined by key speakers. The first one is going to be Dr. Michael Adenkule. We will also be expecting the Minister of Health from Uganda, Honorable Ruth Asheng, who, by my standards and by the standards of many, has early this month launched the world's largest malaria vaccine program in her country, in Uganda. She's been speaking to us about that. And before we invite Jane, if she joins on time, others will move to the panelists with Edwin, I would like to ask Dr. Michael Adenkule himself, a recognized specialist in malaria control, in health systems development, in global health and public health, and currently the CEO of Rollback Malaria, which works very closely with WHO and ALMA. So, Dr. Michael Adenkule, take it away. Please let us, where are we here and how do we close this gap? Because if malaria will end with us, and I noticed that today, Michael, is the World Malaria Day turns 18, so it's just become an adult. So we are basically saying that this is now the time to end malaria after 18 years of the World Malaria Day. So let us know, based on your experience, where do you move on from here? And where are we here? Over to you, Dr.
Great. Thank you very much, Dr. G. And thanks, Edwin, for the initial remarks. I have a presentation, but maybe before I start, to also say that ending malaria starts also with me, starts with you, starts with all of us. This is a significant day in the life of many, many children, and it's important that we take stock of where we are in terms of the fight for malaria. What can we do? How can we use this current crisis as an opportunity to do things differently? I'm not seeing the slides yet. Thank you for showing that. So I will just go in terms of giving some overview, and then I'll give reflections. I know some of the numbers have already been stated, so I might not necessarily go into some of the details of the numbers, but I will try to give some reflections as I go along. Next slide. So this presentation is really about strengthening malaria prevention in Africa. And as we do know, a lot of the deaths do occur, unfortunately, on the African continent. In 2023, we had close to 600,000 deaths, mainly children under the age of 5 and pregnant women. And this is unacceptable at this day and age, when we know that malaria is both preventable and curable. We should also look at malaria from an economic growth perspective. $1 invested in malaria will give us $40 in return in economic growth. We also did an analysis last year where we found out that if we're able to reduce the burden of malaria on the African continent by 90% by the year 2030, we will have an increase in GDP of 127 billion US dollars. Now, that's 127 billion that becomes automatically available to continue to invest in health, into education, into infrastructure, and into all the other things. So really investing in malaria is really of essence, and it's really in everybody's interest. Also, we see that investing in malaria will ultimately bolster the health systems, especially when we look at endemic countries where sometimes 70, 80% of outpatients are really malaria cases. So if we're able to strengthen that, if we're able to bring down the burden of malaria, all of a sudden we will see that health systems become robust, and we will be able to ensure that we're supporting other health interventions as well. The good news is that we have the tools to end malaria. We have the vector control tools, we have the bed nets, we have the indoor residual spraying, we have the larvicidin, we have the chemo prevention, etc. So we know what works. The question we should ask ourselves is, why are we not making a dent? Why is this not happening? Why are still up to 600,000 children dying every year? Next slide. It's taking time to turn here, but I'll go ahead anyway. So if we look at the world map, we will see that we have about 85 countries that are endemic when it comes to malaria. That means they're there year in, year out, and we're not able to significantly reduce the burden. We will see that on the African continent, almost everything is red, which also demonstrates that really malaria is predominantly based in Africa. We have the mortality in Africa, we have the morbidity in Africa, and we need solutions that will ensure that we have our Africans that are really ensuring that we can bring down the burden. So we have the tools that work, but we need also the commitment at all levels, at the country, at the community, at the national level, at the regional level, at the continental level. And that's why we work closely with all those organs, including the African Union, the regional economic communities, the countries, as well as the communities, to ensure that we collectively are able to drive down the burden of malaria. Next. Now, unfortunately, if we look into the numbers a little bit more, we see that 263 million cases of malaria in 2023 alone. That is huge when we know that we know how to prevent it. It's still a lot of burden, and 80 and 95% of that, unfortunately, is on the African continent. Now, the African continent obviously is not spread equally in terms of the burden. If we look at 5 countries alone, we will see that they're contributing about 50% of the burden of malaria on the African continent. Nigeria alone contributes about 27%. So if we take Nigeria, Congo DRC, Uganda, Mozambique, Ethiopia, they alone are contributing over 50%. So if we're able to focus on these countries, bring down the burden, all of a sudden we will see a different dynamic in terms of the cases that we're seeing and also the deaths. So I think a lot of country, and we're working with all these countries, and I'm glad that we'll also be hearing from the Minister of Health for Uganda in terms of what are the strategies and what are they doing to ensure that we're able to bring down the burden. The next slide is a slide of some good news to say that since 2010, we have been able to have a 40% reduction in malaria mortality. So this is significant. And if we continue in the same track, hopefully then we will get there. But we know that there are hurdles we need to overcome. And I'll come to some of those hurdles in a second. 44 countries have been certified malaria-free. In 2023, we had Cape Verde, that was certified. And last year, we had Egypt. So there is hope. Again, we know what works. How do we ensure we learn from those countries to be able to ensure that more African countries are really moving into malaria certification? We have a country like Rwanda that is actually doing well and will hopefully meet some of the targets that has been set. So again, there is hope. How do we ensure that we spread that hope throughout the continent? We have new tools, we have vaccines, we have dual active ingredient nets, bed nets, and we also have rapid case management and increased access to case management. So all these things really work, and we really need to do more of it. Next. But we also know that, we've reached a critical juncture when it comes to the fight against malaria. We're seeing more and more insecticide resistance spreading, so resistance to our medication, resistance to the bed nets, resistance to RDTs. I have a saying that instead of seeing mosquitoes die when they land on bed nets, because of resistance, we're seeing mosquitoes dance when they land on bed nets. So we need to really take that into consideration and continue to bring out new tools to ensure that we're ahead of the curve. The second thing is we have issues around climate. Lots of floodings everywhere. In Botswana, we saw it recently, in Mozambique. With flooding, obviously there'll be stagnant water. With stagnant water breeding site for mosquitoes, cases go up. We have issues of conflicts on the African continent, unfortunately, where people are not able to get the prevention methods. People are not able to access case management. Again, this causes morbidity, mortality. And then finally, we have the crunch, the financial crunch. So although we know what works, if we don't have the resources to do it, we will not be able to get to the end line. This graph really just shows, if you look at the blue line, that is basically where we are today. It says that, we need to have, the green line is where we should be, and the blue line is where we are today. So we're very much far off when it comes to the cases that we're seeing, as well as when it comes to mortality as well. The good news, again, in the next slide, is that we have the political will. We have been able to engage with our leaders at all levels, especially the 10 high burden, high impact countries. And last year, we had what we call the Yaoundé Declaration, which is really looking at high level domestic resource mobilization, using data as the entry point and data for decision making, making sure that we have that community ownership, making sure that the fight against malaria is collective in terms of ensuring a whole of society approach. This year, we have been able to turn that into what we call the big push against malaria, which is what do we all need to collectively do in terms of revitalizing that fight against malaria. Next slide. The big push really focuses on 6 pillars, which I'll go through very quickly. And it is really to ensure that at the global level, we're better coordinated. I'm sure you would agree that coordination has been a challenge in terms of alignment, in terms of harmonization. And there's a renewed commitment to say at the global level, we really need to ensure that we're coordinating better, we're ensuring resource optimization, we're ensuring that we're not pulling countries in different directions. The second pillar is really around leadership and accountability at the country level. And that's exactly what the Yaoundé Declaration is saying, really ensuring that we put countries at the center, ensuring that we have one reporting, one M&E system, one budget, so that at least countries are able to optimize as much as possible. The third one is really around using data for decision making and really strengthening how we collect data and how we're able to use it as well. The fourth pillar is really around access and increase in terms of accessibility and acceptability of some of these tools that we're talking about. The fifth one is about really developing and preparing for the rapid introduction of new tools. And then the sixth pillar is really around how do we increase financing, because without financing, if we have the best plan, we will not be able to get there. Very, very important to note is that we shouldn't look at malaria elimination from a health perspective alone. It has to be from a whole of society approach. And that's why I'm happy that we have different stakeholders here with us today. You know, malaria has an interaction with gender, with poverty, with development, with climate, with agriculture. So the fight against malaria should not be seen from a health perspective alone, but really from a whole of society approach. Next, I just want to end my intervention with two slides focusing on vaccines. We do know that there are many tools in the toolbox. Vaccine alone is not it. We need to use all this in a combination. But vaccines has been the newest tool on the market. And I think a lot of countries are really embracing this in terms of how do we support our children under the age of 5 months to really get the vaccination. So 4 doses are required for children around five months of age. A fifth dose can be given if needed, but it's not a must. And malaria vaccines, as I said, really need to be used within the comprehensive package. Now, in an ideal world, we will do everything, but we're not in an ideal world because we don't have all the resources. So we're urging countries to prioritize. In some cases, bed nets make sense. In other cases, it's SMC. In other cases, it's vaccine. In other cases, it's a combination of all. But it's really important that we see that all these tools needs to be in our toolbox, and we need to see which one works for which situation and why. The final slide is really around, again, looking into how many countries have been able to roll out. So we have 19 countries that have embraced the vaccinations. We have 3 pilot countries, Ghana, Kenya, Malawi. And again, the target for 2025 will be about 13 million children to be vaccinated. We're working again in partnership with the Gavi Vaccine Alliance, with the countries, with the African Union, with the various stakeholders. I would just like to end on 2 quotes just to stimulate some of the discussion. You know, we know that this year has been quite challenging in terms of the funding cuts. And really, as Africans, we're very much used to, having quotes. So I'll just say, when the drum beat changes, and we have seen that the drum beat is changing, we need to adjust our dance steps. And how do we adjust it to ensure that, we're able to mobilize internally on the African continent for more resources to be able to fight against malaria. The second thing, and the last quote I have, is, by a gentleman called Peter Drucker. And he said, the greatest danger in times of turbulence is not the turbulence itself. The greatest danger is trying to solve the turbulence with yesterday's vision. We need to look ahead, we need to rethink, we need to reshape, and we really need to make sure that we move away from words into action. Ending malaria is possible. We are way away from our targets, But if we come together, we know it can be done. It's been done in Egypt, it's been done in Cape Verde, and that's why the theme for World Malaria Day this year is really important. We need to reinvest, we need to reimagine, and we need to reignite. Ending malaria starts with me, starts with you, starts with all of us. Thank you very much.
I feel like I should clap and say amen at the end of that, especially without rousing closing.
And why not? And why not? And thank you very, very much. So, Edwin, before I move to you to the panel, I want to drag Dr. Michael into the panel, myself, with one question, if you don't mind. Then I hand over to you.
No problem.
You very, very well captured the issues around resistance and climate change and conflict and all these things. We have Mansi was asked a question. Why are those countries, the high burden countries, are there any particular features from those countries that make them high burden countries? But then somebody else also in a Q&A asks, related to your last point, the last quote about not solving the turbulence with yesterday's tools, somebody says, we've tried so much, why do you think we'll succeed now? It talks about vaccine hesitancy, talks about behavior change. Something to say to that, to give them hope that actually it's possible, even with yesterday's challenges, to actually create solutions for tomorrow. Those two, and then Edwin, I'll hand over to you to proceed. Thank you.
Great. Thank you very much. Quick answer to those two questions. The first one is, if you take a country like Nigeria, that is 27% of the global malaria burden. Anybody that has been to Nigeria before will see that it's a huge country. We have 36 states, which is basically like 36 countries. Now, trying to have a common approach there in terms of the fight against a single disease is very difficult. And that's why, we're really gearing all our efforts to those 5 countries. And I'm just using Nigeria as an example, but you can take DRC, huge, with conflict as well. You can take Uganda, which also has, resistance creeping in, which makes the fight against malaria even more difficult. So there are always reasons why these 5 countries really create about 50% of the burden. Now, when we look at, we know what works, why don't we have success? I think for a long time, and if we take the example of countries where they've been able to eliminate malaria, one strong thing I've learned across board is that you cannot, and I repeat, we cannot eliminate malaria from a health perspective alone. And we've tried to do that for so many years, and this is what I'm preaching. We need to look beyond health. I'll give an example of, in Nigeria, in one of the states, rice-growing states, they need a lot of water for rice. It's stagnant water, breeding site for mosquitoes. Whose responsibility is it to do larviciding? Is it the Ministry of Agriculture or is it the Ministry of Health? As long as we're not talking to each other, we will never be able to eliminate it. So what is new is that we need to look at it from a whole of society approach, look at it in terms of the interaction between health, malaria, education, climate, gender, development, infrastructure. We have potholes everywhere. We have, open gutters. Is it the Ministry of Health's responsibility to deal with it? No. So we need to bring everybody, and everybody needs to be accountable. And that's the difference. And I think that's what will make us successful in the fight against malaria.
Thank you very much. A lot of accolades to your presentation. Over to you, Edwin.
Yeah, I couldn't agree more with exactly that perspective. And in some ways, part of what makes the Africa Dialogues powerful is we bring health expertise, but also all the other expertise around, right? So AMREF is an incredible organization on the health side. AXUM is an incredible organization on the economic development, infrastructure investment side. And it's exactly that combination, is how do we bring new tools to the table to solve some of these challenges, especially in this moment where we're almost being told, this is your problem, you need to solve it yourselves. We're going to jump into the Q&A, but before we do, into the panel, but before we do that, I do want to remind people the Q&A chat is open and available. Please post your questions there as we go along. And of course, the general chat in terms of sharing your reflections. Those of us who are on the panel and speaking will keep an eye on those and try and answer those questions as we go along. Also wanted to very much acknowledge our friends and colleagues of the Serum Institute of India, who are our partners in hosting this conversation and previous and future Africa Dialogues. Thank you very much, SII, for continuing to be partners in changing the conversation and really bringing this forward. So let's start on the fun stuff, which is the panel. And Michael, we will still pull you back into the panel, so don't worry. And if you hear us say something that sounds controversial, please jump in and let us know. But let me start with you, with Dr. Datu, who, I think we're all incredibly proud in the role that you've played in the development of the malaria vaccine, which is in some ways is the newest tool in the malaria toolbox to tackle this challenge. And for decades, there's been this critical question: can we build a vaccine that is effective against malaria and gets us into the prevention side versus purely the curative side? So I wanted to open with you, partly to just give people, those who might not be familiar with the vaccine, how does it work, right? And we got a sense of that from Michael, but just expound on that a little bit so that everybody on the call has a good sense of what is this vaccine and how does it work? But then push us a bit further in talking about how do we start thinking about access, right? Because vaccines are only effective if everybody is able to get the vaccine and therefore gain the protection from the vaccine. Over to you, Dr. Mary.
Thank you, Edwin. So a very good question to start off with. So I am speaking on behalf of the University of Oxford and myself, and I was involved in the development of the R21 Matrix M malaria vaccine manufactured by the Serum Institute of India. So this is one of the vaccines that very excitingly began rollout last year in 2024. It is a malaria vaccine that targets malaria before it comes out of the liver and causes you infection. So before it causes you symptoms, basically. And that's where we have seen over many years really good efficacy of 70 to 75%. So that was really exciting for us when we first saw that in our UK trials, but we went through the process of clinical development, transferring trials to Africa, to the target population in terms of from adults to infants. And this is how we have been measuring efficacy. In terms of accounting for access, from very early on in the development, so actually following our phase 2 malaria challenge results in the UK, Oxford partnered with the Serum Institute of India to transfer the methods, and that's how the process of manufacturing and upscale began. Once this happened, that enabled us to then test the new vaccine that Serum Institute of India had manufactured. From phase 1 to phase 3 trials, the Serum Institute of India provided all the vaccine for these trials. And it's very important to Oxford, as to many stakeholders, and I think many of you on this webinar, that enough vaccine is manufactured to reach the target population of African infants, but also at a price that is similar to our EPI vaccines or that countries can afford. And it really is very impressive today that the Serum Institute of India can manufacture up to 200 million doses annually at a price, I believe, of around $3 a dose.
Fantastic. Thank you very much for that initial conversation. We'll pull you in for more insights on that front, but great to hear how the partnership with the Serum Institute has made this possible, especially in thinking about from the production side at scale and at price points that increasingly would make sense for our economies, as Dr. G mentioned earlier. Let me come to you, Olivia, and I'm coming to you partly because I know you do have to run shortly, but the perspective from the civil society is critical. As Michael said, we need an whole of society to be operating in this space. If you can, please share some of the experiences you've had in Cameroon on these conversations from a civil society perspective, but also just as importantly, as we're beginning to tackle this question about financing and affordability and getting to the Yaoundé Declaration, what's our role, especially now that the external support Africa has been receiving seems to be coming to an end.
Yes, thank you to the organizer for this opportunity. Indeed, civil society have an important role to play, even more now than ever, to ensure that as a global community, as countries, we do not drop the ball in terms of ensuring that we can address effectively the malaria response. No financial environment is an excuse to lose children, women or men from a disease we can prevent and we can treat. We have the tools. We are talking about a disease that has effective tools to prevent it. We are talking today about vaccines. We have also the tools to test and treat disease. So it's really unacceptable that we are going to lives from that disease that is malaria. So civil society, following the Yaoundé declarations, where our countries, and we thank our country for taking those engagement, especially the engagement around increasing domestic resource mobilization allocation for malaria in their own national budget. And you really need those declaration to move from words to action. And concretely, it means that in the 2026 budget, which will be voted this year in many countries, we need to see that increase of malaria funding very clearly to procure vaccine, to procure tests, treatment, mosquito net, etc., because we have to have a holistic approach to that, especially in this context. And besides just allocation, it's also key for civil society to ensure that those funding are being used correctly. So community-led monitoring on how the health service and the malaria services are being provided at the community level is very important, ensuring that we leave no one behind, because also with malaria, why are we losing still many children today? Is because there are still children that are left behind that don't have equitable access to malaria vaccine. So first we have to produce those vaccines in a big number, in enough doses for all the children. And then we have to make sure that those communities have access to those vaccines in all of the area where malaria is a risk. And we have to really monitor the use of those funding to ensure that they are used for the purpose of which they were allocated for. And civil society also have to play a key role overall on accountability, ensuring that we are all accountable for the use of resources, for access of services to our population, and really ensuring that there would be no excuses, no barrier to save those children. And I just want to say, for World Malaria Day, the civil society joined forces, several networks, including networks of organizations focusing on TB, HIV. They have joined malaria organization networks to all come together in a joint statement to really encourage our leaders to increase their funding and the best use of those funding. And just to finish by saying that really putting an emphasis on community engagement more than ever is critical, because we really want to put the emphasis on prevention. We don't want to wait for children and women to get sick, to have malaria. We want to make sure that we can prevent that disease. So having an accent on community prevention, education, making sure that each family, each household, with youth, traditional leaders, rural leaders, religious leaders, everyone needs to now step in more to ensure that we have strong prevention community engagement campaign, and we can really prevent that disease. And for the case of vaccination campaign, really increase education campaign, working against infodemics and fake news around the vaccine, to ensure that the communities are well informed and actually increase that demand for those vaccines, and ensure that all the children that are eligible to receive the vaccine at least get vaccinated. Because, like I said, there's no context that can justify really losing our children to this disease that we know how to prevent. Thank you.
Fantastic, Olivia. And I hope you're able to stay on for a bit longer, because I'm sure this conversation will yield some interesting perspectives. But let me ask you one quick follow-up question. So you talked about what needs to happen at an institutional level, right? So countries, resources need to be available, and civil society needs to play its role in doing that. You also talked about civil society itself needs to engage with community. any perspectives on what people need to do, individuals at an individual level, any successes where you have seen individual action itself, because ultimately that's where some of this needs to sit, in addition to the institution from a funding perspective, governments providing resources and the vaccines being available. How about the person-to-person side of things?
Yes, that's a great question, because usually when we talk about malaria resistance, we are focusing on the vector resistance, insecticide resistance. But one of the biggest resistance we are seeing in malaria is us, is human resistance, is us not wanting to use a mosquito net every night, us not wanting to vaccinate our children, us not wanting to keep our environment clean. So we are also, as communities and humans, part of this resistance problem. So it's important that we take accountability and ownership. I know many still maybe have to have the right information, but that's why it's going to, the multi-sectoral approach will be very important, ensuring that this is not just a health problem, but that we can increase educational programs with Ministry of Education, increase sensitization program with the media, with Ministry of Communication. But we really have to get the right information about how to prevent malaria, and ensuring that we come back to the center of this fight and we do our own role with malaria behavior that will help to support all the efforts of the government. If we don't do this, we are going to lose our own children. It's not going to be the children of other countries. It's going to be our children, our fathers. And we have a concrete example of women in Cameroon. There's a woman called Flore who has last year had seen 7 or 9 of her children all got malaria in her household, and she was devastated, and she has to spend a lot of money just to treat all of them. And this is really affecting also our economics and our power to even take care of education and take care of other issues. So as communities, we have to get informed, connect with our malaria control programs, with our CSOs, get the right information, and really build very strong community engagement mechanism at the community level. If each village, each house, each neighbor, each village decide that we are going to make the malaria prevention and fight a priority, we're going to really fight back this disease. And this is actually what is needed at the moment, more now than ever, and it's possible to achieve.
Agreed. Some of these challenges can feel so daunting that the easiest thing to do is to externalize and say it's somebody else's job, it's somebody else's fault, it's somebody else who's not doing their action. But we as people and as individuals need to do our own action in our households, in our communities, appropriately if we're going to win this fight against malaria. So thank you very much, Olivia. Good luck with your next session, and looking forward to continue to engage on this important discussion. Let me come to you, to Dr. Tinto, because many people do not appreciate that Africans have been at the forefront of the development of the vaccines themselves, right? Most of us might not be aware or are not as, think vaccines, things happen elsewhere. It's other scientists elsewhere who do the thing, and then we get the product. But you've actually been at the forefront of decades on this research work, and seeing the vaccine finally, a meaningful, capable, effective vaccine finally come forward is almost a pinnacle of your career, right? So first of all, congratulations and thank you for dedicating your brain and your mind and your energy to getting us here. But I wanted to pull you in talk about Burkina Faso's role in the clinical trials themselves, in the building of the vaccine themselves. What are the things you would love everybody on this call to appreciate as now we are having World Malaria Day and we're saying this must end with us? What are the thoughts you'd want to share?
Thank you very much. As you mentioned, I'm coming from Burkina Faso, where 12 million of malaria cases were reported last year, and with nearly 5,000 deaths, unfortunately. And you can understand why we have a big interest of investing our effort to fight this disease. And then Burkina Faso became the center of the R21 malaria vaccine development, because this is where it has been reported for the first time that a malaria vaccine can reach an efficacy of over 75%, thanks to the investment of my team and my colleagues. And this, of course, paved the way towards the phase 3 trial that allowed the recommendation of the R21 vaccine. But it's important to stress that before R21, Burkina Faso was also part of one of the 11 sites that contributed to bring RTSS on the market, because we're part of the phase 3 trial, and we should all be grateful to RTSS, as this vaccine was incremental in the leadership we have now in the country. Because thanks to the facility built by the RTSS phase 3 trial, and including the lesson learned from the experience with this trial, we are now able to develop the other vaccines, including R21, and we are now working with another group in Oxford, together with Serum Institute of India, to develop the next generation of malaria vaccine, including the RH5, so the blood stage, which really shows promising results and have the potential to open the door towards the combination of vaccines targeting different stages of the parasite. What began as scientific challenges for me and my colleagues turned it into a historic public health achievement that we are all proud of in Africa. Today, I'm happy that we have on hands promising tools to make malaria history with the introduction of the new vaccines. But let me tell you that having good vaccines will not be enough to roll back malaria, as we should find the most appropriate and efficient approaches to really deliver this vaccine, and make sure this vaccine will reach people who really need them. And everybody is talking about vaccine hesitancy, etc., cold chains, but there is one challenge that many of you are not talking about: the issue of the coverage. This is a very important issue, because this morning I was listening to the radio, and it came out that in Cameroon, for instance, the API is struggling to reach 50% of coverage with the third dose of the vaccine. I anticipate that the rate of the fourth dose will be worse, because they reported 50% of coverage with the third dose. So it tells us that yes, we have a good vaccines, but we do not have perfect vaccines, because a vaccine for which you need 4 doses in our context, the health system context in Africa, could be a big challenge. In the phase 3 trial of RTSS, for instance, we have clearly demonstrated that without the 4th dose, you cannot maintain the vaccine efficacy over time. You will maybe maintain it over 1 year, but not beyond that. That is why I would like to really take the opportunity of this tribune to raise the awareness about the need to test new approaches, new innovative strategies to sort out this issue of low coverage of the 4th dose. Otherwise, it will be a waste of time, a waste of money, and people will complain about this vaccine. They will say, oh, you have introduced this vaccine, but we don't see any change. But in fact, to have a change, we need to deliver 4 doses of this vaccine. So this is, for me, a big worry as a researcher, and as a researcher, we should really work on that and propose to the Minister of Health of our countries an innovative approach on how we can increase the coverage. And we are working on that. We will maybe come back later on that. Over to you.
Fantastic. That's a really, really important point. And the way I think of it is we have version 1 of the vaccine, which is clunky and not great and requires a lot of effort. Hopefully we'll get to version 2, 3, 4, 5 that becomes much more effective, but at least we know it works, right? So step 1 is it works. That's good. Now let's make sure that we continue evolving it to be even more effective and even easier to deliver to our people. And so thank you again, Dr. Tinto, for all your work in getting us to here. But as you clearly say, the job is not done. There's more to be done. And so we'll come back to you shortly for just additional thoughts. Zakaria, let me come to you because you've been thinking on how do we integrate the vaccine into the malaria toolbox across African countries, right? So it's one thing to have a product that is out there in the world. It's another for it to be available to every single African. What are the things that you would be able to share from that experience that are worth our audience understanding and recognizing?
Yeah, thank you very much. And also, I think for this invitation, and I concur with what has been said by other speakers prior to me. And I think I also want to take this opportunity before I make my comments to really appreciate all the great men and women across the world who've invested a lot of their time and energy and even resources into developing the current crop of malaria interventions and tools that we have now that is actually giving us a fighting chance against this disease. I think that's very important to recognize, especially on World Malaria Day. And I'm very delighted that Dr. Tinto and Datu are both here, very remarkable contributions. Coming to your question, so a lot of what we have been working on and doing, especially as an organization, has largely been trying to focus on two fronts. The first one being the expedited deployment of these interventions, especially the vaccines. And secondly, trying to ensure that these interventions are deployed in the right quantities. Now, we can go into the specifics of why this is important, but what is most critical, I think, to accept here is that malaria continues to claim about 1,000 children in Africa every single day. So when you think about 1,000 children per day, it's a very, very serious situation. And if anything, we should all be addressing this issue with a lot of urgency as an emergency that it is. So that's one, which is why a lot of what we've been advocating for and a lot of what we've been doing and what we've been pushing for is trying to ensure that these vaccines are deployed quickly and in the right numbers. Now, there are considerations that have to be made when embarking on such a very complicated, logistically involving process. But some of those specific considerations, especially now, are hinging on funding. I think we are in a very different landscape when it comes to public health funding globally. And that's why, unfortunately, a lot of the countries that are dealing with malaria, are countries that are low and middle income. So these are countries that have to make very serious considerations and trade-offs when deciding where to spend every dollar they have. And part of that logic also now goes into how to make the interventions like vaccines, how to make them, number one, cost effective, and number two, acquire as much coverage as possible. So the question of integration of malaria vaccines into other routine immunizations is actually one aspect of trying to be cost effective. Because a lot of these countries that are trying to roll out vaccines in Africa already have infrastructure and skills that they've been utilizing for other pediatric immunizations that have been going on for years. So the goal would be that with the introduction of new tools such as vaccines, it will be more effective or more cost effective to try and integrate these vaccines into already existing structures without needing to reinvent the wheel. Because trying to create separate delivery mechanisms, separate timelines, obviously involves costs. And this is money that currently doesn't exist. So this is why these kinds of considerations are very important. Now, also, it's, I think, important to mention quickly here that because of the nature of the way these routine immunizations are scheduled in different countries, and also because of the geographical locations of these different countries, the kind of seasons that are experienced in each of these countries, the considerations are very unique. for each of these countries. So it's not January for all the countries. It's not March for all the countries. It's not, it's December for the countries. So each country has to actually analyze each of these factors to make a decision. But I also quickly maybe just touch on the issue of why the integration becomes also important. The vaccine that we're talking about, whether it's RTSS or R21 especially, they are all 4-dose regimen. And I think, as Dr. Tinto mentioned already, the issue of following up on latter doses is an issue that needs a lot of effort, a lot of attention. And I think this also underscores the importance of civil society organizations and advocacy. And I'm very glad that Olivia is here as well. So continuously engaging with the communities, with the public, with the ministries, will continue to create accountability and monitoring that will make sure no one drops the ball, as it were. Because if we, no matter how driven we are, if we manage to roll out the first dose and the second dose and we forget, and think about 3 months, 4 months, 5 months have passed, what will be the meaning, or what will be the consequence of trying to continue from a 3-month gap or 4 months gap, especially that the current scientific data that we have, it requires that these doses should be spaced 1 month apart, except for the 4th dose. So this is why in some instances, countries have to restart, as it were. And I'll refer to the most recent WHO position paper on the malaria vaccines, which has actually created some wiggle room for flexibility in terms of interchangeability and also a continuity of these vaccines. So the way to understand, I think, integration of the malaria vaccines and the tools is mostly to ensure that we are remaining as cost effective and saving every dollar that we can in the rollout of these malaria vaccines. And there's more that we can discuss or talk about on the specific considerations that each country has to make sure that it is remaining cost effective when deciding which of these options is going to roll out for its populations. Thank you.
Super, super useful. Thank you very much for that, Zakaria. And the point you make is so important on, you need to have all the doses for this to be effective. And because we tend to look at this from a systems perspective, we think of this as, what does a system need to do? But we also rarely think about the cost to the citizens themselves, right? These are tens of millions of children who need to be vaccinated, which means tens of millions of women need to spend substantial amounts of time to take their kids for the vaccine 4 times, right? And that is massive economic impact. And so it's important to really think about the end-to-end impact, what the respective designs have, because we are asking society to do things differently, right? So something to keep at the back of our minds, even as we think about what does that redesign, what does a new formulation of the vaccine looks like. And so the challenge is still on, Datu and Tinto. We'll come back to you to just give a preview of what that future begins to look like. But let me pause briefly, Dr. G. I don't know if you've been tracking the Q&A chat, which I see has been moderately active. The chat has been more active, but there are a couple of questions on the Q&A. Anything that stands out to you that is worth highlighting to the panel for consideration of discussion?
Yes, definitely. It's been hot and fast, actually, on the Q&A and also the chat. I couldn't keep up. I'm trying to listen. I'm trying to keep up with the questions. This is the beauty of the Africa Dialogue. So I have many of them. The first thing I saw someone actually is, I think it's Eliane from WHO saying, Mali has also introduced malaria vaccines today as the 20th country. So we continue to have gains, and thank you so much for giving us that. There's a dashboard. She's presented a dashboard there where you can monitor which country is doing what. So 2 key questions amongst the many. One is adult vaccination. I've seen multiple questions asking, is it available for adults? I think there is somebody who's asked Professor Tinto that in Burkina Faso, it seems you're vaccinating multiple ages. So could somebody comment on adult malaria vaccination? Number 2 is the question around local manufacturing, whether there are any plans from the scientists to actually drive this towards local manufacturing in Africa, because more than 90% of cases are in Africa, more than 90% of deaths. So why manufacture it elsewhere and bring it here? So are there partnerships that are being created with the manufacturers, with owners, to also drive a little more community security in the continent? And then there's many questions around behavior change communication. And I think that's what was summarized earlier as human resistance. So what do we do? And this is related to the question, and not only hesitancy. Actually, I like to say in Africa, many cases of hesitancy are not actually hesitancy. They are lack of access. And then they are concluded to be hesitancy. But if vaccination is happening Monday to Friday and the mother is working and therefore has to come to the clinic on Saturday or Sunday and the clinic is closed, so what we call hesitancy is often also lack of access. So the key question is here, in Africa, we have a lot of zero-dose children already. How do we ensure that these new innovations don't layer inequality on top of inequality? So there are quite a few questions, and the panelists can pick them as they wish.
Yeah, I think that's a fantastic set of questions. It also shows our audience has been actively listening. So at least we have an active audience on this. And to your point on hesitancy, it's exactly that, right? The cost of people going to get access to the vaccine, so they don't show up for the third one or the fourth one or the fifth one, is not because they don't believe it is important. Sometimes because actually it just doesn't work, right? The economics of it. What it takes for them to be able to go multiple times for the same vaccine can be challenging. So let me come to you, Dr. Tinto and Datu, and I will ask a general question, but also if you can wrap in some of the questions Dr. Gidenji has posed in your responses is, what does the future look like from a scientific, from a vaccine product perspective? And, none of us can predict the future, perfectly, but if you said, look, the future looks like this, or at least these are the kinds of things we're trying to make happen, and here's a sense of when that future will come, we will try not to hold you to account of the exact date, but at least generally, this is the direction of travel. Why don't you do Datu and then Dr. Tinto right after?
Sure, thank you. So aside from the current geopolitical situation, I think the future is bright. We do have the tools now, but of course we are relying on everybody, from government to global health organizations to funders, as well as people in the field, implementing partners, and of course the caregivers and children who are to receive the vaccine. And we all need to work together to achieve this objective. But I say the future's bright because we have 2 malaria vaccines that are being rolled out. This was not the case on World Malaria Day last year. It was just one. And Tinto alluded to this earlier, but we excitingly already have next generation vaccines that are quite far in development. And hopefully these can improve on the existing vaccines. In terms of the questions that were posed, so thinking about adults, I think Prof. Tinto will speak to it more, but I initially did some early phase trials in adults and we saw good efficacy, and that's why we took the vaccine further. But Tinto has been involved in a major elimination trial of R21 going on in the Gambia and in Burkina Faso. And so we are now soon to see the effect this will have on a large number of adults at a country level. And the other thing, just to mention, the Serum Institute of India have been collaborating very closely with African partners. And there is a real effort to try and see what can be done locally. We completely appreciate, we know that there was significant inequity during the COVID pandemic. We don't want that to happen again. And we are aware that it is really important to try and capacity build, and manufacturing or fill and finish, etc., is very important to try and be done in Africa. And so I think some steps are being made to try and progress this. Thank you.
Professor Tinto?
Yes, thank you very much. Thank you, Maureen. As I mentioned it in my intervention, I clearly say that, yes, we have good vaccines, but probably these vaccines are not perfect, because a perfect vaccine should be a vaccine that you can deliver in one injection, for instance, without any repetitive dose that will increase the coverage. Because if you look at the 3 injections in the primo vaccination with R21 and RTSS, you see that for the first dose, we can easily reach 90%, 80% of coverage. But with the second and third dose, you see a decrease coming down to 50% in Cameroon, for instance. So one way to improve the existing vaccines is to work on the number of doses. The other way, and this is where we are working with Serum Institute of India and another team in Oxford, is to move on towards the combination of the vaccines. Instead of using, for instance, R21 that avoid the affection of the liver, we will combine a blood stage vaccine to create a second level protection at the blood blood cell level. So because the vaccine is not 100% efficacy, so you have 25% of the parasite that can escape the liver stage to reach the blood stage and make you sick. So the strategy will be to create another barrier at that stage. With that, we expect that we will have a vaccine with an efficacy over 90%. This is our hope, and we will see what will happen. So this work I've just started, and now we'll vaccinate the first children before the end of this year. So next year, probably we'll have the preliminary data. Coming back on the vaccination of adults, yes, Marine mentioned that we are conducting currently a mass vaccination, seasonal vaccination for the malaria elimination. And we are working in the Gambia and Burkina. Why the two countries? Because Gambia is near elimination, and Burkina is a country where malaria transmission is still very high. And the objective of the project is to go in a population and vaccinate everybody, adult, adolescent, children, everybody. And the preliminary results are quite encouraging, because 3 months after the third vaccination, we reported in Burkina a reduction of 30%, which can be seen as moderate. But if you consider the number of malaria cases reported in Burkina, 12 million, it means that you cut that 12 million by third. So 4 million of malaria cases averted. In terms of public health impact, this is huge. And in the Gambia, I think we have around 50% of reduction, which is also very good. And we think that if we are able to combine both the vaccine and the mass drug administration, we should be able to improve that rate of efficacy. Over.
Super, super useful. And we're just scanning the people in the audience, and we're trying to see if we can pull in Dr. Corinne and Aline into the conversation. So just be careful. We might just promote you and have you answer a few questions. And these are individuals who've been at the forefront of the malaria fight, leading their respective country programs at initial stage, and then very much going and having global roles. So would love to make sure that we give space for everybody to engage. Zakaria, let me come to you on the the integration of the vaccines and what that future looks like, especially as we have next generation vaccines potentially coming into play. There is one world where, yes, you have the product, yes, it's manufactured, but is it, do our regulatory environments actually, have they okayed the use of those vaccines and being able to then do the rollout at an aggregate level? Do we have the funding that is, and increasingly domestic funding to be able to fund for this? And I know that you're at the forefront of exactly these conversations, especially from a vaccine equity perspective. What are lessons that have been learned from other contexts that we need to bring to malaria, so we're not reinventing the wheel, but also are there unique challenges that we also need to think about beyond the 4 or 5 doses required?
Yes, that's a very good question, and thanks for highlighting it. So I think I'll begin by saying, like other panelists, I think the future is bright, the future is promising. And with those words, I also want perhaps to take this opportunity to emphasize that the world of science is very dynamic. It's always alive. A brilliant, innovation today can be beaten tomorrow, quite literally. So that's why science must always keep on pushing for better, solutions, better interventions, diagnostics, and therapies, treatments, and preventive interventions, as it were. So with that statement in particular, what I'm trying to perhaps emphasize here is that while the world of science and researchers are building what will be the world's next generation crop of vaccines or interventions, what we should do now is not to sit and wait for those next generation interventions, because children right now, as we are speaking, are dying. And I cannot emphasize this any stronger. We cannot continue to allow this situation to happen when we have tools that can help to mitigate this issue or this problem at now, not tomorrow, not next year, not 10 years from now, right now. So the emphasis remains that the available tools are effective. I mean, it's true, as Dr. Tinto has mentioned, they're not perfect, but they are effective. And there have been a couple of studies that have been done trying to assess the actual impact in terms of all-cause mortality, which was done on RTSS. And also there's been some studies which were also done on R21. So even if you are reducing mortality by 13%, as was the case for RTSS, or by 30%, I think that's a win we should proudly take, because 30% sounds like a fraction, but this represents thousands of children who get to live a full and healthy life. This represents thousands of families who don't have to bury their children, below the age of 5. So this is why it remains very important that all the available tools that are at our disposal right now should be maximally utilized. Now, I'm not singling out vaccines only here. I'm talking about vaccines. I'm talking about seasonal malaria chemo prevention. I'm talking about indoor residual spraying. I'm talking about using insecticide-treated business. I'm talking about larviciding technologies and other vector control methods. All these tools have to be used. And this is what actually gets us closer towards bringing malaria under control, and perhaps we can begin to see eradication or even elimination in sight when we do this. Now, as you have rightly said, there are several challenges. We have talked a lot about funding. That's true, but there are other, process-specific challenges. And I'm very happy that you've mentioned the issue of regulations. So part of the thing that actually, in a manner of speaking, determines the pricing of some of these vaccines is how many steps have to happen before a vaccine reaches the target population. Now, we can simplify this process, of course, remaining, safe, of course, and ensuring that there is the highest possible quality that we can demand, but we can reduce on how much, steps that manufacturers, for example, have to go through to get these vaccines for children that need them. Now, to give an example, and this is in a broad concept of trying to harmonize regulation in Africa, for example, Serum Institute of India, which manufactures R21, has to do the regulatory process in Kenya, for example. It has to do regulatory process in Uganda. It has to do regulatory process in Tanzania. It has to do regulatory process in Burundi. These are all East African countries who are currently using the same passport, by the way, right? They trust each other enough to use a single passport. So why are we not trusting our scientific data? If one country has done review of a scientific or medical pharmaceutical product and has certified it to be safe in collaboration with other WHO regulations and approvals that have, usually go before the countries can take a look at the data, like the recommendation and pre-qualification. The third part of the country adding regulation is basically, honestly speaking, a bonus. So I don't think there's great incentive why manufacturers should be subjected to this. Imagine 45 countries trying to roll out malaria vaccine, and the manufacturer has to do all this in each of these single countries. And these are actually some of the things that delay the deployment of the vaccines. And secondly, they increase the cost of delivery for the manufacturer. And ultimately that cost comes back to ourselves who are trying to use the vaccines. So, for example, by harmonizing continent-wide or regional regulations for the introduction or registration of vaccines, we could, number one, cut on time. And as you know, if we're losing 1,000 children per day, cutting on time from our regulatory processes means we are actually preventing children from being infected and some of them from dying. I think that's very important to view in that case.
Yeah.
And beyond the regulation side of things, I think there's also need for a collaboration in terms of even the specific rollout plans that we are trying to, deploy in the countries. So as I mentioned earlier, countries have different seasons, and these seasons appear at different times of the year. So by that happening, we can actually pick lessons within the countries or regions where we have similar weather or similar, climate, as it were, where we have similar demographics and things like that, so that we are trying to work in collaboration, even if it's regionally.
Yeah.
That will go a long way in trying to, mitigate that issue that we are currently facing. And the last point, maybe I've been going for a while. The last point maybe I would like to raise here is also on our assessment of these interventions. Now, this is something I have said before in some conversations, but when you are a continent like Africa where the funding is very limited, and we've been talking about this for a bit of time now, you need to decide very critically, because of the issues on last mile delivery or zero dose areas, as it were. If you have, let's say, 2 vaccines, and one does not need you to refrigerate up to, maybe you can have it for 2 weeks without needing refrigeration. It has good thermostability. That is actually time that you can use to deliver to the last mile possible within the country without needing extreme refrigeration or cold chain. So these are very specific small considerations that ultimately contribute to making the process simpler and even the handling much easier. I think I'll pause here. We could go on and on this one. Thank you.
Thank you. Thank you very much, Zach. And because this platform tends to be not very successfully so, but tends to be a bilingual platform, I want to request Professor Tinto, because there's a question that was asked by Abubakari, and he asked it in French. And the key question he's asking is, we seem to be focusing a lot on vaccines and not on the vector. And the vector, and I've seen many people talk about the vector, the conditions of the vector development, public health, precision public health, community engagement. So even as and it's been made very clear by Zach that we are not just talking about vaccines here because that's the only tool. Actually, it's just an additional tool to the existing ones. So could you probably in French handle this question around the exhaustive approach to malaria control, community engagement, and also there is a question around whether it's efficacious in people who've been previously exposed to malaria in endemic areas. So you could cover those in French. And for those of us who are English speakers, just go down to the button written more and click, look for the interpretation, which is a globe, like a globe, a round thing, and choose the language of your choice. Over to you, Professor Tinto, in French.
Oh, Prof, you're muted. Prof Tinto, you're muted.
Oh, sorry. Thank you. Yes. Merci beaucoup pour la question. Je pense que lorsque j'ai fait ma présentation, pour celui qui a posé la question en français, j'ai été très, très clair en disant que nous disposons certes de très bons vaccins, mais nous ne disposons pas de vaccins qui soient parfaits. Un vaccin parfait, c'est un vaccin qui peut être, par exemple, administré en une seule injection. Ça va éviter les déperditions parce que, je l'ai dit, au Cameroun, par exemple, ce matin, il a été rapporté que moins de 50% des enfants recevaient 3 doses du vaccin RTSS qui a été introduit, alors que tout le monde sait que si le vaccin n'est pas donné à 4 doses, on ne pourra pas protéger l'enfant dans la durée. Cela a été démontré dans les études de phase 3 avec RTSS, que si vous vous limitez à 3 doses et vous ne donnez pas 4 doses, la protection ne va pas dépasser 1 an. Alors, le fait qu'il n'y a pas un vaccin parfait et que ces vaccins ne sont pas efficaces à 100%, parce que R21, comme vous l'avez vu, c'est 75%, RTSS a été rapporté à 55%, tous les deux de très bons vaccins qui entraînent une réduction du nombre de décès liés au paludisme, mais également du nombre de cas. Mais vous avez encore 25 ou 50% de risques de tomber malade. Donc, c'est pourquoi l'approche pour vraiment accélérer l'agenda du contrôle du paludisme doit être une approche holistique, dans laquelle vous combinez tous les outils existants, non seulement les vaccins, mais également les moustiquaires, également le renforcement du système de santé, parce que sans un système de santé robuste, tous ces outils ne peuvent pas être déployés de façon efficiente, jusqu'à ce que peut-être dans le futur, et nous sommes en train de travailler là-dessus, c'est de proposer des vaccins qui puissent protéger à 90%, pourquoi pas à 100%, en essayant de tacler le parasite à plusieurs stades de son développement, parce que les deux vaccins qui sont disponibles empêchent l'entrée du parasite dans le foie. Nous sommes en train de travailler dans un nouveau programme pour tacler le parasite dans un deuxième lieu qui est le sang. Ça veut dire que les 25% ou les 50% de parasites qui vont échapper au foie seront bloqués au niveau du sang. Et ensuite, il y a d'autres équipes qui travaillent pour le bloquer chez le moustique. Donc, ainsi, on espère dans les années à venir aboutir à un bon vaccin qui peut être presque à 100% efficace. Mais pour le moment, les outils existants comme le contrôle des vecteurs, comme vous l'avez dit, doivent être toujours utilisés à travers les moustiquaires imprégnés, les pulvérisations, dans l'espoir qu'on pourra se passer de tous ces outils-là si un jour nous avons un vaccin plus efficace. Merci. Thank you.
Thank you very much, Dr. Tinto. Dr. G, I was expecting you to actually ask the question in French, but clearly...
No, I saved the, people had not transferred yet to English, so I wanted to give them that.
So you're giving them time. You're giving them time to pick the right translation.
Voila, voila.
Let me come to you, Aline Maliwani, who is the head of the care department in the National Malaria Control Program in the DRC. Aline, you've been an active participant in this conversation, and so wanted to give you a chance to just share your reflections, somebody who's at the forefront of driving the malaria response in one of the critical countries from a malaria response in the DRC. Aline, any thoughts that you want to share before we close?
Bonjour à tous, moi je vais parler en français. J'espère que vous m'écoutez.
Yes, we can.
Vous m'avez entendu, je peux y aller? Je peux parler?
Oui, vous pouvez y aller.
Ok, merci
Oui, s'il vous
beaucoup.
plaît.
En tout cas, je remercie tous les intervenants dans ce panel qui est très riche et qui est en train de nous instruire encore davantage. Parce que comme vous le savez, en RDC, nous sommes en train d'introduire le vaccin contre le paludisme progressivement. C'est-à-dire que les quantités qui arrivent ne nous permettent pas d'y aller partout au même moment. Donc, nous sélectionnons les zones éligibles, c'est-à-dire d'abord les zones à forte transmission du paludisme, où on est en train de privilégier d'introduire le vaccin contre le paludisme pour avoir un impact. Mais sinon, j'avais une question. Je voulais savoir si le vaccin contre le paludisme pourrait interférer avec les résultats des tests de diagnostic rapide du paludisme. Comme vous le savez, le TDR est un test antigénique et le vaccin aussi est un antigène qu'on injecte dans le sang. Donc, la question est là. Est-ce qu'un enfant qui a reçu le vaccin contre le paludisme pourrait-il avoir aussi un TDR positif suite à la présence de l'antigène du vaccin dans le sang? Merci beaucoup.
Dr. Tinto?
Yes, thank you. Merci pour votre question. Alors, je peux vous rassurer d'ores et déjà que le vaccin contre le paludisme ne perturbe pas les résultats du TDR, tout simplement parce que la protéine qui a permis, ça veut dire la substance qui permet de fabriquer le vaccin, provient de la forme du parasite lorsqu'il est injecté par le moustique dans l'organisme humain. Ça veut dire qu'il empêche l'entrée du parasite dans le foie. Et donc, si vous voulez, l'antigène qui sera utilisé dans ce cas, c'est un antigène de la forme du parasite avant qu'il ne rentre dans le foie. Alors que le TDR s'intéresse à détecter le parasite lorsqu'il est dans le sang. Donc, ça veut dire que l'antigène qui sera utilisé et détecté par le TDR se trouve au niveau du parasite lorsqu'il passe de sporozoïde à mérozoïde Et ensuite, quand il rentre dans le sang, il est trophozoïde. Et donc, vous voyez que c'est deux protéines complètement différentes. Donc, il n'y a aucun risque d'interférence. Là, je peux vous rassurer. Je ne sais pas si j'ai répondu à votre question.
Oui, oui, c'est très clair. Merci beaucoup.
Merci.
Super, super useful. I love that that happened in French at the end, and my high school French is not good enough to translate. So thank you to the interpretation, and it also meant everybody who's at the dialogues actually gets to experience interpretation on the other side, and this is so important if Africa will actually come together and fight some of these issues together. Is we need to have the experiences that other people have, and usually because most of this conversation in English, most people kind of breeze through it. But our colleagues and friends and family who are on the French-speaking side have to go through interpretation. And so it's great that everybody gets a bit of that experience. We only have 4 minutes to go. And so one quick lightning round question for all the participants, for all the panelists, sorry, Michael, yourself included. When we gather again next year, because we will gather again next year, what's the thing that gives you greatest hope that we'll have made meaningful enough progress, so not incremental progress, but hopefully a substantial step change in ending malaria in Africa? So let's do Michael, Datu, to start, Dr. Tinto, and then Zakaria to close us out.
Yeah, good question. I think for me, the hope would be, if we look at the landscape at the moment, the fight against malaria and the funding, a lot of the funding is still coming externally. For me, if we're meant to carry a heavy load, we should be the ones carrying the majority of the load, not externals carrying majority of the load. So hope for me is that, we will have increased our own share of resources that is going into health generally, not just malaria, but into health as a whole.
Right.
The second hope is that I'm hoping that we don't look at malaria from a single lens perspective, but that we can integrate as much as possible with other health sectors, but beyond health. Those are my two hopes that I'm hoping we'll be talking differently this time next year.
Fantastic. Dr. Datu?
Sure. So I think similar to Dr. Michael. So we are a real turning point in the fight against malaria. I think by integrating all the existing interventions that we have for malaria, as well as now the horizon where we have the rollout of 2 malaria vaccines. But similarly to as said, I think this requires real ownership with local countries by national government for delivery and implementation, but also advocacy externally from global partners for financing and providing the vaccine. I appreciate it needs to be done locally, but I think it actually needs to be a multi-pronged approach. But again, as previously said, very positive. Let's reinvest, reimagine, and reignite together.
Yeah. Dr. Tinto?
Yes, thank you very much. From the discussion today, I can clearly see that a world without malaria is finally within reach, but without the necessary investment and resources, will not make it. That is why I would like really to echo what Charles has said, to call for more ownership and more leadership from African governments. And we recently published an opinion letter in BMG where we were questioning whether global health security worth 0.01% of our gross domestic product. And we propose that all countries, regardless of the level of their income, should support and contribute, including high income, middle income, and low income countries. And we hope that in 1 year time, African will really take the leadership and the ownership of the malaria, of the fighting malaria in Africa. Thank you.
Asante sana. Zakaria?
Thank you. Thank you very much. I think for me, when next year comes, what I would be very happy to perhaps learn or hear would be that we have done a better job of integrating the vaccines into malaria care or management. Because from where we are right now, since the 2 vaccines were introduced, there's only a total of 19,490,000 doses that have actually been deployed since the two vaccines were deployed. That's roughly just under 20 million. And if it's a 4-dose regimen, you can estimate how many children actually have gotten vaccinated, give or take your confidence level. So for us, for me, I think if we can double that number next year, I think that would be a great amount of success.
Right. And I just did this quick search. Thanks to ChatGPT, it says that we have about 46.1 million children who are born in Africa every year. So to put that in context, that's 160, 170 million doses that are required every year. And so everybody on the call, think about how big that difference is, right? So we are a tenth in terms of what we are producing versus the 4 doses required. We must redouble our efforts. And I want to be clear, my call is there are things that institutions need to do. Multilaterals, bilaterals, governments need to do. There are things that communities need to do, and there are things that individuals need to do. And in this entire conversation, it is important to make sure we don't lose sight that all those 3 actors must act if we're going to end malaria. And so my urge to everybody on this call is, yes, let's keep fighting and keep pushing on the institutional side, but let us not forget our own individual responsibilities in our own communities. Let us not over-externalize what needs to happen. It doesn't have to be us waiting for the government to clear the bush outside my house. I can clear the bush outside my house, right? It doesn't need to be the government that is doing a massive campaign around vaccines and I'm waiting for this to be on radio. I can call up my friends and cousins and siblings who've just had children and say, this is important. That is the way we fight this and we win this war. And so my urge to all 300 people who are on this call today is to be an active part on all those dimensions that are required. But for closing remarks, I'll come to you, Dr. G, to bring us home.
All right. Thank you so much. I have just a very quick 2 or 3 messages. One, somebody did ask whether the participants will be receiving certificates of participation for their CMEs. And yes, I confirm I've checked with the team. We'll be able to send you certificates of participation for these as a CME, as a continuous medical education. Second is to thank our partners, of course, AXUM, my colleagues at AMREF and SII, for enabling us to pull together such a fantastic panel to discuss. And all I've seen is thanks and great conversation. So thank you very, very much. And finally, to say that Africa will need to be an A-class continent. And for it to be an A-class continent, it will need to rely on A-class citizens. And the job of making A-class citizens is Africa's job, not anyone else's. But because Africa will do it itself, doesn't mean it will do it alone. So we invite partners, but the job is ours to do with the partners that join us. Thank you, everybody. Please remember that malaria ends with you. And thank you for joining the Africa Dialogues. Until next time, bye for now.
Waheri. Take care, everybody.